And is it on the do not disturb?
Flight mode.
Flight mode.
It is. Yep.
Yeah, good. All right. Are we good?
Good. Hey, mate.
Hey, how are you?
I'm very well. Well, welcome back to Australia. You've had a bit of a holiday.
I have, yes.
How long were you away for?
6 weeks.
You haven't put the other mic on, fucker.
Oh, you're going to have... Oh, so this one, yeah.
Yeah, so that one as well will add to good audio on both phones.
Yeah,
as
good.
opposed to just one. So when we do edit them in, they should be fine.
Good.
G'day, mate. How are you? It's been
great.
a long time.
It has been too long.
Too long. You've been overseas.
I have, yes.
Back to
few
the motherland.
weeks. Yeah, to go back.
Nice.
But I missed this.
Yeah, it's been a while, hasn't
Every
it?
day there.
Oh, yeah.
Yeah.
Very good, mate. Very good. And so I'm assuming that your time over there, you were spent going, what else can we talk about?
Exactly.
What are the things that interest us at the moment?
Yeah.
So, and you come back and you start talking about pelvic binders. Like, why on earth are you thinking about pelvic binders when you're over the other side of the world with your family on holiday?
Yes, good question. No, it came up in the feed, of course. The Americans are now recommending, they're not strongly recommending against pelvic binders, but they're encouraging EMS services to look at whether or not to ditch the pelvic binder altogether.
Oh, that's interesting.
They wouldn't call it pelvic binder, you know how academics are, you know, it's a pelvic circumferential compression device.
Ooh,
PCCD.
Yeah, of course it is. No worries, because we need another acronym.
Yeah.
Yeah, definitely. So somebody's written about it? Is there a paper out somewhere?
The National Advisory sort of Committee for EMS Physician in the States is saying we know from literature that it's positioned wrong in up to half of patients. Every second patient you put a pelvic binder on, it's placed too high. Yeah. In which case there's no benefit in terms of the pelvic binder, and there's lots of risks for iatrogenic injuries. So something to consider whether, if we're going to use it, we better know where to put it on, I'd say.
So I immediately go, rather than removing it, would it not be better to teach people where to put it on appropriately? Or if people are having issues or identified issues when they arrive at hospital, should there not be direct education for the people that have applied it?
I like it. That sounds sensible. But but I think the reason they're not pushing for that is that, on the other hand, there's no high quality evidence to say that it does work.
Sure.
So even if we got people to put it right over the greater trochanter and tight enough and tie the legs together and do all the appropriate things when you want to reduce the pelvic volume, even if all that was done, that's not sort of guarantee that that'll show an improvement in mortality and morbidity. But here in Australia, we still use them. When would you put a pelvic binder on, Shep?
There's lots of instances, and there's lots of specific mechanisms which you would look at and go, that person definitely needs one. And the big ones that spring to mind for me are motorbikes. Motorbikes over the handlebars. So as they go over the handlebars, their knees often click onto the handlebars, which sort of separates their pelvis as they actually go over. So that's a big one. Head-on collisions, if you look at somebody who's had significant impact to the front of the knee. And the big one for me is smashed knees equals smashed hips. So you think about that force that's cut their knees open, that gets generated straight up through the femurs and smashes through the back of the pelvis. So they're a big one for me as well. So frontal impact collisions, side impact collisions, significant intrusion into the B pillar. Those sort of patients, they've had a lot of force going there, and sometimes there's not too much room to move. Older generation cars, you could probably move across your seat a little bit more, but we're a lot snugger in the cars nowadays. So maybe that can be a good mechanism. What was the other good one I was thinking? Pedestrians. Pedestrian, the right height, you get the right car that hits a person at the right height. Obvious mechanism for a pelvic fracture. So they're the big ones to me. The other one, final one, falling. Falling from heights. People that fall off a building, land, and depending on how they land, whether they land straight on their bum or land on one leg, can determine the type of pelvic fracture that they'll actually have. So I'm going to throw one back at you because you're the doctor that's done more study with anatomy and all the rest of it.
Oh no.
There's obviously several types of pelvic fractures that we can come across. To me, the obvious one that we want to be finding is the pelvic open book fracture.
Open book,
Talk to me about that.
Yeah, look, I think you've described the mechanism for the sort of three types of pelvic fractures. There's the AP, anterior posterior force, that could open the book or open the pelvis, and this would be associated with a lot of bleeding because there's a lot of arteries and veins, things running on the inside of the pelvis. You break that open, high risk of bleeding. So,
what sort of volume are we talking about within that intra-abdominal cavity there?
Lots.
Yeah, it's like 4 to 6 litres.
At least the whole baby's worth.
Yeah.
Because that's what comes out, isn't it?
Yeah. So I think it's around 4 to 6 litres of volume that we can contain within that pelvic cavity. So probably, it's huge. Yeah. Huge.
The other mechanism and other way of classifying pelvic fractures would be like a lateral compression. So whether there's impact from the side or falling off the side, like you say. And then the third would be the shearing mechanism. So if you jump off a balcony and land with one leg before the other,
splits the
pelvis might shear. So, would there be any type of pelvic fractures where you definitely would not put a binder on?
Oh, it's hard because, you know, we're always taught about sticking pelvic binders. What were they? PCCDs
PCCD
onto patients.
Can you just say that over the phone next time? Yeah, it's the clinician here.
That's my challenge.
Have you guys applied a PCCD?
Yeah, the next sit rep I give to a hospital will include that. So I think the important one to me is if you've got an open pelvic fracture with bony fragments on view or anything like that with the pelvis involved, then I probably wouldn't be applying it in that type of circumstance. I guess the other one, they talk about significant lateral compression. So the side of the pelvis is being caved in from significant lateral force. The application of a pelvic binder in those type of patients will obviously increase the amount of pain. And they all get an increase in pain, but we can talk about that in a moment. But I think it's associated with further damage to vessels and so forth. So if they've got massive, obvious crush to the lateral side, I believe in the literature those pelvic binders are not supposed to be applied in those type of patients.
Not be helpful,
Once again, refer to your own services guidelines for recommendations as to when you can't apply them.
You just mentioned there, I just realised with the words how it can be confusing, right? Because there's open book fracture and then there's an open fracture.
Yes, it is.
So they're particular with calling a pelvic binder a PCCD, but...
I can see your brain ticking here about another acronym.
We need a new term.
Here we go. This will be the Alex acronym for pelvic injuries.
No, just to the point you were saying, like a contraindication for putting one on. If there's bone on view, this would be an open fracture, just like an open tibia fracture where you can see the bone. It's an open fracture. But when we talk about an open book fracture, we're just saying the pelvis is normally like this. And if you get significant AP force, it's open.
And I want to emphasise that an open pelvic fracture does not mean a little nick where you can see the top of the iliac crest or something like that. I'm talking about a significant open wound with obvious fractures of the pelvic bone inside. That's what I'm talking about. Not just a simple, like we get the fractured femur where you get a poke out and then it pokes back in and we've got a little hole and so forth. I'm not talking about that in those sorts of circumstances. I want the open wound with obvious pelvic injury.
Yes, you'd want to avoid it then. I think that's sensible.
There's not a huge amount of contraindications to its application though.
No.
So I think, we've mentioned the type of injuries that we've had, the open pelvic fracture, pelvic book fracture being the most common one that we actually want to identify and actually correct and manage. There's times when we go, it's got a mechanism of injury, but I'm not quite sure. Do we apply it in those ones?
Yeah, tell me. I mean, what sort of other clinical indicators do you need? So if their heart rate and blood pressure is good, they're maintaining GCS 15, but they've been in a car accident, do they get a pelvic binder? Or do they have to be shocked or hemodynamically compromised? Or
I think at the end of the day, the fallback mechanism or the fallback theory would be if you have concerns about it and you believe the mechanism was such that there's a high likelihood of a pelvic fracture, then the application of a pelvic binder in the correct position would be warranted. I guess you've got to think about, what's the issues of actually applying a pelvic binder to someone who has your suspicion but actually doesn't have one? So if I put one on you because I thumped you in the hip and you're really sore and I think I've broken your pelvis, but you haven't, what sort of complications are you going to get from its application?
Pressure injury would be the first and most significant, and these things stay on for a while. And you know, it's not as though when they hit the hospital door that we take these things off. And, you know, if it's put on pre-hospitally, it'll be a while before they come off in hospital, and there'd be radiology, you know, X-rays or CTs before they come off. Typically, you'd see some trauma centres that have the X-ray sort of in the resuscitation cubicle. If the pelvic binder's on, loosen it, get a picture and see if there's an open book, and then put it back on. But yeah, that's a concerning moment, and people looking at the blood pressure very carefully and stuff. But so if you take a patient to a non-major trauma centre, that pelvic binder will stay on for a while before there's scans and someone sort of looks into it further and decides to take it off. So, but it has to be applied correctly. You know, when they looked in the literature, 50% were placed in the wrong spot, most of them too high up.
Yep.
And like, it's not a belt, you know, a belt sits on top of the pelvis. That's not what this is. This is
a PCCD, mate.
It's a PCCD. That's what the episode will be called.
Oh, yes, yeah, absolutely.
PCCD or not PCCD, yeah.
Now, I want to take you back. I want to go back into the hospital. So, major trauma centre, we take somebody in.
Yeah.
Major trauma, pelvic binders in situ.
Yeah.
They get it done quickly. Like you said, they'll get an X-ray and they'll likely get a CT. Can they clear a pelvis from just an X-ray?
Well, we'll be reassured that it's not a significant open book. So, because the risk is that the pubic symphysis, when you take an X-ray with the pelvic binder on, it looks pretty good. Looks anatomical. You take the binder off. If the pubic symphysis sort of falls apart, then bang, the pelvic binder goes on, and they go to the CT and pick up the phone to the orthopedic guys. But
I'll add in there while you're still thinking.
Yeah.
Do they automatically get a CT of the pelvis, or we go in with this mechanism, suspicion, no obvious changes? We've put a pelvic binder on. They've taken an X-ray. Is that person going to get a CT, or are they going to go, no, we're happy with just the X-ray that we haven't opened up when we've released it. We've taken an X-ray. Everything's still in situ. Yeah. Does the pelvic binder stay off at that point? Yeah,
it's a good question. I mean, you know, every case on its merits, but if someone gets a CT trauma scan, that goes down to the pelvis. It'd be very rare these days to do sort of dedicated imaging. Sometimes we just do head and neck, head and cervical spine, and avoid the rest. Young people or females where you want to avoid radiation as much as you can. Yeah. You could stop there and, you know, chest X-ray, pelvic X-ray, and then assess clinically. But they have to be hemodynamically stable. And but if we scan any further, they get the cap, chest, abdo, pelvis, and then there's a lot of pelvic fractures that you can't see on X-ray. Absolutely, and many of them aren't clinically significant, like a little pubic rami fracture or something. Very hard to see on X-ray, but they could have significant pain, but they're not hemodynamically unstable. So there's tons of vessels there, and if you disrupt the pelvis, any of them can bleed and ooze, and as you said before, several litres could go in there. And so if we're then saying, what's the purpose of the pelvic binder? It is to cause some hemostasis. Yep. And what's the purpose?
Well, the purpose is obviously, if you've got an open book fracture, is to close the pelvic rim so that we haven't got an open one. So if you open it up, it increases the volume within the pelvic cavity, so you can bleed more into it. So if we close it, it decreases the amount of volume. By doing that, it can control potentially the amount of bleeding that you have inside. The other thing when we do it is we actually stabilise this. If you've got a loose fracture and it's flopping around in the breeze, it hurts. So if you don't actually take control of the pelvis, then it's going to hurt when you do any sort of movement. Every bump that they go over is actually going to hurt them. So the big thing with that then is a reduction in pain. So, you know, pelvis fractures are really sore, and it's like if you've got a busted femur, when you pull and align the femur, the muscles relax a little bit more and you get less pain and discomfort. The same with a fractured pelvis. If you stabilise it, stop it moving around, then obviously you're going to reduce the pain. So that's probably the main things off the top of my head that you need to be thinking about and why we actually do it. So we're sort of jumping backwards and forwards here. Now I'm going to say car crash, motorbike, whatever it is, this person's lying on the floor. We've got the mechanism is shooing. And so we were talking about before, what other things do we want in our head to make us go, yep, mechanism, and
Yeah.
what else do we need to be applying the pelvic PCCD?
Yeah, what other to consider? Yeah, I think mechanism plus, whether there's any signs of physiological derangement.
100%.
So,
Good. So
yeah,
you mentioned before,
or
good,
shock.
hypotension, shock,
And
tachycardia.
a baby of mine is the shock index. You see some guidelines around the world use this to sort of decide when to put it on. And it's just heart rate divided by systolic blood pressure, and you can come up with the perfect number where that ratio gets a bit off. But easiest to remember is if the heart rate's more than the systolic, they're at significant risk of shock.
Yeah. That's a good one. I like that. Heart rate greater than your systolic. Yeah. That's an easy one, isn't it?
We're trying to dumb things down.
Even I could remember that.
Yeah. No, because, as you get worse, the heart rate goes up and the blood pressure goes down. So it's much better to take the two as a ratio, because then you pick up subtleties sooner. And,
great tip.
There's tons of studies out there measuring the optimal shock index for when things start to go pear-shaped, and that's probably 0.9. But if the heart rate's 105, the blood pressure's 98, you're going to sort of pull out the calculator. And, well, in that case, the heart rate's more than the systolic. But no.
So good. So those other things that you mentioned there. So physiological values are really important. So good mechanism, physiological values. Obviously, when you look at the patient, obvious open book fracture, splayed. The other one is I look at the feet, and if their feet would normally be sitting like that, but they're turned outwards and splayed out to the side, that's a big thing for me. One leg shorter than the other, does that make you think? Yeah, especially in shearing forces, they've copped a force and they've done that. That's another good one for you. The big thing for me is pain. Like I said, even people who have a fracture of the pubic rami, even though physiological, it's not affecting them that much, they'll have pain with it. It's a busted bone, so it's going to hurt a little bit. So are there any tests that we can get them to do, like bending their knees or lifting their legs or anything like that, to sort of see if we can get a increase in pain with any sort of movement? The big one, obviously, you can't ambulate. That's a good one.
Yeah, so in the cohort of young trauma patients, good mechanism, yet I don't think you want to be start doing movements to try and exclude a fracture, but in elderly with a low impact sort of fall, although that's a significant mechanism for them, the typical course in hospital would be some imaging, whether that's X-ray initially, and then see can they mobilise. Oftentimes they can, but exclusively sore sort of in the groin, that would have you suspicious of a pubic rami fracture, for which the treatment's just sort of pain relief and physiotherapy and trying to get back to normality. There wouldn't be any surgery for those types of small fractures. But no, it's an interesting topic, and I think pelvic binders have gone on very rapidly in the past, and it's part of a thing. It's part of the whole sort of trauma management. But now there's concerns that more than half are malpositioned, most of them too superior, and when they compared females to males, it's even more incorrectly placed in the females. So if we're going to do it, we better do it in the right spot. We should do a video on where to put it, but there's tons of stuff out there.
We can most definitely do a video on where to put it. But like you said, there's 1,000 different videos out there. So I was just thinking of lots of things in my head that I wanted to ask you about, but now I've got a mental blank about all of them. So I think, we talk about the rush to put a pelvic binder on our trauma patient, and sometimes it can be simple things like a fall or minor trauma, but from my experience, paramedic crews are sometimes very, what's the word for it? They apply it without thinking too much because of the reception that they may get at the hospital if they haven't put it on. So there's a lot of people that we would go to that you go, oh no, I don't think so. I think they're pretty much fine. But I better put it on just in case the hospital gives me a hard time. Well, we've all heard about hospitals, when you get busy and so forth, sometimes your reception can be a little bit rough. And they've taken patients in which may have been indicated for a pelvic binder and copped a bit of a ribbing if they haven't actually applied it. And vice versa, there's no real indication for it and they've applied it and copped a ribbing as well. And there's obviously, as we've mentioned at the start there's a lot of things to consider by applying a pelvic binder for a long period of time can be uncomfortable for a patient. So that's probably one of the things. The training for application of the pelvic binders, this has to be thrown back onto the individual. If you don't know where to do it, go and ask somebody who knows.
Yeah.
Go and spend some time in your training room, get the pelvic binder out and put it on each other. It's the only way you're going to get better at it is if you practice it. So you can read as many textbooks as you want, you can watch as many videos as you want, but I'm sure most ambulance branches will have a training binder which you can go and apply on each other and practice.
Yeah. Yeah, and you certainly don't want to be fluffing around in front of patients and family, not knowing where the hooks and the Velcro go. And I get that muscle memory down and just do it a bit lower than what you think.
And there's lots of different binders available. Obviously in Victoria we use the SAM splint binder, which is generally a 2-person application for the device, but it can be applied by one person if you don't have the resources to actually do it. But you should be practicing with your partner who you're working with and go, hey, let's just go through this together. You know, if you can't roll the patient, how are you going to get it up underneath them? And there's lots of things that we carry in our bags with slide sheets and all that sort of stuff, which can assist in application of pelvic binders. So these things you need to practice. You need to spend the time in the training room and actually go and do it. I think in New South Wales, they use that looping mechanism pelvic binder. Have you seen those ones? Yeah, they've got this multiple little things. We'll put it up in the video. I'll pull up a video of it or a picture of it. And it's got a looping mechanism. I don't know what the name of it is. I've never used it, but it's another type of pelvic binder that can actually be applied. So there's lots of different ones out there, and depending on the ambulance service that you actually work for will determine which one to use. Yeah. We're getting towards the end of this, mate. I want to talk about management. Yeah. So we've put it on. What else do we need to do? Do we just put it on and leave it like that, or do we can mobilise anything else?
Anything that you could do to reduce the pelvic volume, and you mentioned before, like a suspicion for a fracture is if the feet are splayed outwards. So just like you would with an off, bring the feet to the middle,
so good to
tie them together.
Yeah. I've turned up to multiple cases for multi-trauma patients that crews have gone, tick, I'll put a pelvic binder on, but your job's not done if you're concerned about the pelvis until you've splintered those legs together. So my recommendation would be, if you can, something between the legs, a towel or something like that, so you haven't got bone on bone banging together. And then support it across the femurs, maybe mid-calf, and then do a figure 8 bandage around the feet as well, which will hold everything in alignment. Makes it more comfortable for the patient, but also can help reduce that volume.
Anything else you can think of?
Medications, mate.
Analgesia, TXA.
Yes, big one. Yeah. Well, check your guidelines as to when it's recommended within your service, obviously. But definitely TXA would be a good one if you've got the hypotension, the tachycardia, and everything that's pointing in that direction. So that would be good. But analgesia, let's talk about analgesia. So as we've said, you can get simple pelvic fractures that don't actually require much analgesia. They're fairly stable. Pelvic pubic rami fracture, it's not moving, it's not displaced. It's not going to be too bad. Open book pelvic fracture, bit of discomfort with that. Hit them hard.
Yes. Get the pain under control. Because if there truly is bleeding, if you can get the pain under control and improve the heart rate with that, you'll have less squirts out of the arteries per minute, and just purely sort of humanitarian, like you want to help people's pain, calm them down. So keep them warm and comfortable. Fentanyl seems to be the drug of choice these days.
Yeah, what about if you've got long transport times? Like if we're over an hour away, and we talk about the difference between fentanyl and morphine. Morphine obviously lasting a bit longer than what fentanyl would. Would a preference be, or it doesn't really matter at the end of the day, whatever's in your drug bag, I suppose.
Yeah, the morphine versus fentanyl debate. That's another podcast. I guess morphine works a bit longer, but what is it called? Hives, nausea, hypotension, respiratory depression, the lot. So,
ketamine.
That's just a bit of vitamin K.
Well, we better say ketamine because people will start giving vitamin K.
Oh, no. It is,
So ketamine is a fantastic drug and very good. And infusions of ketamine as well. You manage your patient with your initial narcotics and introduce ketamine and get them into that sweet spot, and sometimes the consideration of a opioid infusion plus or minus a ketamine infusion can make them really comfortable. And I would suggest that for long transport times on very uneven surfaces. But if you're 5 or 10 minutes down the road from a trauma centre, then bolus doses of opioids and or ketamine would be appropriate for that type of patient. What about non-steroidal anti-inflammatories? Like in the helicopter environment, they use paracoxib. There is some discussion that paracoxib can increase bleeding.
Yeah.
Certainly within our guidelines, it's not a contraindication for its administration with
Yeah.
that type of patient. Would that be reasonable?
Yeah, no, it's a risk for sure. But if you could control the pain with opioids and ketamine alone, would you not stick with that? Or would you have to be sure that there's no bleeding before you go to the NSAIDs? Or you just give it empirically?
Yeah, so we call it the little bundle of care that we give for the trauma patient. We talk about things like intravenous Panadol, opioids, ketamine, and non-steroidal anti-inflammatory. So we get hit from every angle. And you think about the lasting effects of giving a non-steroidal anti-inflammatory early is that obviously it provides good analgesia for the patient ongoing, as opposed to the boluses that we give patients.
Yeah.
So it's that synergistic effect that we always talk about of having lots of medicines working for the patient. So there's probably no answer that we can give to it immediately, but I guess it's a consideration. If there isn't an obvious contraindication to the medication to be given, then go ahead and give it.
Multimodal analgesia, that's
Yeah, absolutely.
So the PCCD, the pelvic binder, that's to reduce the volume in the pelvis. So we've spoken about putting that on, tying the legs together.
Yep.
Could you think of any other crazy ideas of how to reduce the volume within the pelvis?
Well, not crazy ideas, mate. Have you got something up your sleeve?
Yeah, there's case report material on this, and we did this at Alfred years ago. Mark Fitzgerald's ID. You ready for this? Put in an IDC. Fill the bladder with some saline.
Oh, right. Yeah.
And the convert, because then, you get a full bladder in there, that's going to compress and stuff. And where sort of that idea came about was that someone had a really full bladder, and then when they got the IDC put in as part of trauma care, the blood pressure dropped. So, hang on, that's full liter or two of bladder. That was causing a lot of tamponade. So maybe
conscious patient or unconscious patient?
Yeah, conscious.
Because that would be extremly uncomfortable.
Look, can
you imagine when you think about, I need to go for a wee, and I go, I'm busting, and then all of a sudden I'm in a shitload of pain because my pelvis is busted, and I'm feeling crap because I've just been in an accident, and then you come along and stick a catheter inside me and fill me up with 1 or 2 litres of saline. I'm talking about excruciating discomfort here. So I do like the idea, though, that internal tamponade. But I think on a conscious patient,
well, there'd be analgesic and,
in the K-hole.
Hey?
In the K-hole.
In the K-hole, in the ketamine hole, So, but I'm not saying, pre-hospital should start putting IDCs and filling it up, but it is worth being aware that a full bladder causes a bit of tamponade. So if you put in an IDC or you do an inter-hospital transfer and that's been put in, we're ready to go, all right, we'll go in the plane. Just before you go, 1 minute, we'll put the IDC in for you so you can drain it on the way. Just be on the lookout for the blood pressure that next
That's a really
5,
interesting
10, 15
point.
minutes.
I like that. I think, definitely the intubated patient would probably be a bit easier to manage. The conscious patient would obviously add to their discomfort, requiring you to then give more analgesia and all the rest of it to get over the top of the uncomfortable feeling that they would have in their pelvis. I think, it's good. It's got merit. Because we do a lot of inter-hospital transfers for the trauma patient to bring them back to trauma centres. So that's certainly something to consider. I've never heard of that one before.
And it's one of the last things we do. So if a sick trauma patient comes into a rural hospital, we make the call straight away. We need some help getting them out of here. And whilst that's being organised, scans are being done, treatment lines, whatever. And it's really, it takes as long to do all that as it takes for you to arrive. You want us to put an IDC in before you go? Oh, yeah, sure, I'd imagine there'd be some saggy blood pressures. If there's a true pelvic fracture and oozing.
There's a research paper in that.
Let's do it.
That as well.
I know.
So I think catheters in the pre-hospital environment, probably not.
I think,
but definitely for those in-hospital transfers, that would be a reasonable consideration, and certainly I've got it up my sleeve just in case. Something to think about. Alex said on the podcast that they can keep some fluid in the bladder just to reduce the volume. Good, I like it. So one other thing, we've spoken about giving lots of medications. I am a huge advocate for nasal end-tidal capnography. So this person that you're pouring the drugs into, it's great that you've got their pain under control, but if you're not watching their ventilation and respiration, then you're going to run into issues. So put on nasal capnography for any patient that you're providing large doses of analgesia to, because you want to see what their end-tidal CO2 is doing, and make sure that they're not maintaining good oxygen sats because you're blowing in oxygen to them, but then they've got rising hypercapnia. So just a simple tool that you can apply. You'll get your most accurate respiratory rate you've ever had in your ambulance history.
Yeah, that's right. Yeah. When people report to respirator, 17.
16. Oh, 17.
Well,
17.
16. Well, 16, that's someone that just had a look, that's 16.
Yeah.
But if someone says 19, 17, there's monitoring on.
There's monitoring on, that's right. Or they're smart enough to go, I've written too many 16s, I'm going to throw in a 19.
But if you do 17, you'd have to count it over 2 minutes.
Yeah.
And divide by 2. So, Great, I think that's it.
So we've covered everything. IV access, obviously, this person is potentially going to require blood. So large bore IV access, obviously any port in the storm, if a 22 is all that you can get in the back of the hand initially, that's great, but don't go sticking 22 gauge cannulas into cubital fossas, which need to have bigger needles for later blood administration. Obviously at hospital they can go to other areas, or they can do rip lines and all that sort of stuff later on. But consideration for a larger bore cannula for blood administration will be really important. Oxygen consideration is the other important thing. Do they or do they not apply oxygen? I think if they've got good oxygen saturations and no chest injury, oxygen's probably not required. Spinal immobilization, high mechanism, that force, distracting injury, cervical spinal immobilization would be the other good thing. And ultrasound, we didn't even touch on ultrasound, mate. So this is one of the great things that you can do. Talk about a shearing injury, open book pelvic fracture with internal bleeding, point that ultrasound down towards the bladder and see what you've got, see if there's any evidence of internal bleeding there as well.
Yeah, ultrasound's coming for sure, and it's been so expensive for years. And that's in the screen, it's not really the probe. So now that everyone carries around,
we should reach out to one of the providers of the ultrasounds for a little handheld one and see if they can just throw us one that we can demonstrate.
We should, but you got the phone there, you got the probe there, and even if you don't know what you're looking at, you could very soon, I'm sure, just stream that video to someone who can help you interpret the image and say where. I did this a few years ago, before I had much sort of ultrasound practice. I just FaceTimed, so you had the screen, the probe, and they got the FaceTime on. Here's where the probe is, here's what the camera shows. That looks like cholecystitis, send them off elsewhere.
The technology is definitely there, and I think there's obviously privacy issues as one of the considerations, that there isn't somebody tapping into the network somewhere across the world and picking up the images that you're actually sending. But once they get over that, that's once again another podcast in itself. But I reckon we've tapped on most things there for the session. Is there anything else you can think of? No,
I think just to be aware that some of the world is now moving away. You're being cautious about pelvic binders. And in a place like the States where there's a lot of private services and stuff, if there's any umming and ahhing from the guiding bodies about where the pelvic binders work and they don't have demonstrated benefits, they're not going to waste the money stocking that. So there'll be, I'm sure, over the next few years, a push away from pelvic binders on the proviso that, there's no high quality RCT that it works and it might cause iatrogenic injury. We're going to keep them, and
we're going to train people to use them better.
Education is the solution, not removal.
So they want to remove stuff because people haven't applied it correctly. Let's teach people how to apply it correctly. So that's going to have to be one of the videos that we do. Even though there's 10,000 videos out there doing exactly the same thing, we'll add to it.
People want to see you put one on, mate.
Good on you, mate. Well done. Thank you. PCCD.
That's it.